social issues. They may not understand things that we say sometimes, which I experience a lot when we're trying to talk fast and we have 5 minutes to explain something. We have to think about partnering with our patients and redesigning our clinical spaces differently so that we're really communicating and working together on some of these tough outcomes. We also need to work better with each other. So we have a lot of different drivers that are focused on how doctors communicate with nurses and how nurses communicate with administrators and how administrators communicate with doctors, and really thinking about how we report things consistently and change our work environment and culture. And then finally, we need our leaders to care, right? We are actors in large, complicated systems. If our hospital CEOs are more interested in orthopedic surgery because it's more profitable than maternity care, we're not going to get very far. So we really need our CEOs, our elected officials, our leaders at the Department of Health to care about mothers and maternity care so that we have the resources we need for quality reporting and so that we can change our clinical environments. I'm not going to bore you to tears, but we have this crazy big document online that you can read if you're really interested by what we're talking about today. That is our change package. And our change package is our menu. And hospitals are picking from this menu to decide what changes they're going to focus on the ground. Each hospital picks their personal aim, their goals, their strategies, and the benefit of something like this type of initiative is that it's group accountability. So everyone had to sign on the same day. We will quit on the same day, though we may extend that date based on how things are going. We've had 3 in-person meetings. We will have 3 in-person meetings. So I think Tracy and Lisa and Paula joined us at our last meeting in Lafayette, which was in January. We're right in the middle of our initiative right now, so it's a great time to kind of get briefed and get aware of how we're doing. And every month we have coaching calls, we're doing site visits, and really everything we can do to get these 31 hospitals on the same page. It's sort of like I don't go to the gym unless I'm meeting someone at the gym. That's kind of what this initiative is doing. We're trying to keep these 31 hospitals on the same page, on the same pace with implementing these changes. Each hospital is being asked to report on 7 measures, and we're going to talk about a couple of these today. So every hospital is reporting in on quantitative blood loss, whether there's a risk assessment for hemorrhage, whether there's been timely treatment of hypertension in patients with hypertension, your elective delivery rate, your C-section rate, and whether you're doing drills and debriefing after a severe maternal morbidity event. Do we think a 20% change is possible? I think so. So these are quarters starting with 2016 going through the second half of 2018. So 2016 to 2018. And this is our severe maternal morbidity rate among women with hemorrhage. And you can see that based on quality improvement work that's already been happening in the state, there is this gentle downtrend. Now, some of our hospitals code transfusions, and some of them don't. And even when we ignore the transfusion codes, there's a gentle downtrend. I could spend some time explaining this data, but if it's boring, I can move on. Do you have questions about what this graph is capturing? On this axis is our rate per 10,000 hospitalizations, and this line represents our severe maternal morbidity rate. And in this case, we're only looking at women who've had a hemorrhage and whether or not they're experiencing that extreme morbidity. And we're seeing the rate gently track down. So we think that this 20% improvement really is feasible. We also think that it's feasible in the preeclampsia cases. And you can see that even with women with preeclampsia, transfusion, this darker gray line represents our SMM rate, counting transfusions. This just reflects the fact that women with hypertensive disease are also more likely to hemorrhage because a lot of the severe maternal morbidity in these cases is still accounted for by transfusion with a need for hemorrhage. This is just some data on how our hospitals are doing. So we have a lot of work to do. For some of our measures, we have 1/3 of our hospitals reporting on measures every month. For some of our measures, we only have 5 or 6% of our hospitals reporting every month. Luckily, East Jeff is leading in this regard, reporting on a lot of measures, and also East Jefferson is actually not just reporting on measures, but stratifying that report so we can see which patients from which different racial backgrounds or which different provider management styles are kind of showing that response for each measure. And I'm going to talk a little bit more about this in a bit. But I'm showing you this because a collaborative means we are all trying to work together. Now, some of you, I think, deliver at multiple hospitals in the area. Some of you, well, all of you have colleagues, friends who are delivering at other hospitals in the area. Our goal for this initiative is that everybody in the state knows that for the next 12 months we are reducing morbidity due to hemorrhage and hypertension. So we need to activate our colleagues. I might be losing friendships because I talk about this too much, but we want to activate our colleagues and really test, are we all doing the best we can to improve the coordination of our patients' care and to improve our patients' care on these measures. So what can we do here? I've given you a little bit of the overview of what the collaborative is doing. We have a huge collaborative structure. We have faculty from different institutions around the state, including Dr. Holman, Dr. Gillespie from Ochsner and from LSU here in New Orleans, who are helping to educate different hospital staff and physician groups around some of these changes. We want to talk a little bit to you about things that you can do right now, right here, to help control this maternal health crisis, to help make that line not go up quite so fast. So here is an example of a case from our maternal mortality review that kind of relates to hemorrhage. This case happened very recently, so this particular one is from the period between 2014 and 2016. This is a real case. I've just taken out some of the identifying details. This woman initiated prenatal care at 10 weeks. She had 11 prenatal visits. She was admitted at term for induction of labor. There was no medical indication for that induction of labor. During the labor, there were subtle signs of fetal distress, and she underwent a C-section. After the surgery, she developed incisional and vaginal bleeding in the recovery area and received uterotonics at the bedside. However, her bleeding persisted, and she ended up going back to the operating room after about 2.5 hours of kind of follow-up notes about her level of bleeding. An XLAP was performed in the operating room to re-explore the wound. A moderate amount of blood was noted in the abdomen, and there was some bleeding from her uterine incision. There was some exploration of the wound. It was thought that there was no focal kind of point of bleeding, and the laparotomy was concluded. The patient was closed. Upon attempting to transfer her back to the recovery room, she started to have excessive vaginal bleeding. At this time, blood was ordered. Emergency blood was released. There was persistent, now heavy bleeding from the hysterotomy, and a hysterectomy was performed. The patient became unresponsive in the operating room, so this was all taking place under regional anesthesia. The co-team was alerted. At this time, she was bleeding from all of her operative sites and her upper abdomen. And after extensive efforts and initiation of transfusion of blood products at this time, attempts at resuscitation were discontinued. I have a hard time even reading this case out loud because I think we've all been in situations that some element of this case reminds us of, and you can just imagine the trauma that with this for the providers and also the stress of that moment. But when this case was reviewed by our maternal mortality review committee of your colleagues, of our colleagues, it was determined that this was really a preventable pregnancy-related death. If she hadn't been pregnant, this wouldn't have happened. And by preventable, meaning that there was a good chance to have altered the outcome with different clinical decisions or management. Now, some of the things that were discussed in the review setting were, it's always hard to know because we're looking at documentation and charts. We weren't there. We don't know exactly when different things happened or what conversations were happening. But if it's not documented for the purposes of a review like this, we don't know that it happened. And so some of the things that were pointed out were, how much bleeding did she actually have in that first surgery? Her blood loss was not separately recorded for that first surgery because it seems like everything happened, in a stream, and so there's no separate blood loss for each of these kind of visits to the operating room. What uterotonics did she receive? Not in the physician's notes. Maybe perhaps at the time that this happened, there wasn't an EMR for our case abstracted from the Department of Health to review, but we don't know exactly what she got and how much she got. At what point was it decided that she'd go back to the operating room? Should she have gotten blood sooner? And that was actually the thing that, our maternal fetal medicine colleagues really said, is that it seems like if she was having so much bleeding, initiating that transfusion earlier really may have made a difference. I guess we'll never know. Should she have been closed? What could we have done differently in this case? And I don't know if you all have any other thoughts just from reading this of what comes to mind.
I think you hit some of the high points of a lot of information. I said what you were talking so much. They exhaust other options.
And what was the time frame on all this? how fast did everything happen?
Right.
What laboratory, I mean, it sounds like her coags had to have been completely out.
Right. So I don't remember seeing the labs for this case. There was an autopsy that was done, and the autopsy did show, you know, the coroner and the pathologist reported that they thought the cause of death was DIC. So, I mean, that's sort of obvious from the course of the story. But you get an idea. Now, this was not the only hemorrhage-related death that we reviewed for that time period. This is sort of a representative case. And when we look at our severe maternal morbidity rate, so now I'm looking at morbidity, not mortality, so this is going to be a larger pool of cases. And now on this graph, I'm looking at race. So the blue line is women who had a severe maternal morbidity, who had an obstetric hemorrhage, who are Black. And the green line is women who are white. We do also see, on top of this being kind of a concerning level of cases, so this 3,000 number up here means that there are 3,000 cases for every 10,000 births of women who had a severe maternal morbidity in the setting of having an OB hemorrhage. We can definitely see also that there's a racial disparity in this outcome that's surprisingly consistent over time. So again, this is the first quarter of 2016 and this is the mid-quarter of 2018. So in addition to seeing these outcomes, we're also seeing a racial disparity. I want us to keep...
So you're saying that in that quarter, 4,000 out of 10,000 Black women had obstetrical hemorrhage?
It's a rate. So the rate is 3,000 for every 10,000, yeah.
3,800 for every 10,000?
So it is a calculated rate. The denominator of Black women isn't 10,000.
Okay.
We can break down the numbers. So an example of what would go into this would be, I actually have an example here. So let's say there were 16,000 deliveries in a quarter in the state. And of those 16,000, about 600 had an SMM event. That rate, if you look at just the women who had a hemorrhage, the denominator comes down, so the rate looks a lot bigger. Does that make sense? So the denominator of women who had a hemorrhage would be about 8,000. And the main thing here is that there's this very consistent discrepancy between Black women and white women. When we look at what we can do, so when we thought about what opportunities for prevention are, we're not making this stuff up. We don't need to reinvent the wheel. We know that the California Maternal Quality Committee has developed tools that they developed in response to their maternal mortality review findings. So readiness, there's sort of these 4 tiers: readiness, recognition, response, and systems learning or reporting. So in terms of readiness, we're thinking about hemorrhage carts, availability of medications, having a protocol in place, and knowing whether a patient is high risk or not. Now the patient in that case was not high risk, right? She did not have any risk factors going in. She was having elective induction. She did not have, significant history of prior surgery, etc. But then there's this idea of recognition. So are we quantifying blood loss? Are we communicating about how much blood we think we've lost in order to have an early recognition of a hemorrhage situation? In terms of response, we're thinking about emergency management plans and team structures. And then in terms of systems learning, we're thinking about how does the system keep learning from its errors or mistakes, or how do we keep taking opportunities to improve even if we're already doing really well? And I would say this is a facility where we're already doing relatively well, but there's always opportunities for systems learning and improvement. So drills, debriefs, and constant case reviews. When we talk about OB hemorrhage, some of our definitions have changed over the last couple of years. This is the most recent ACOG practice bulletin on the subject from 2017. OB hemorrhage is now defined as a cumulative blood loss of more than 1,000 cc's, or of course, if a woman has signs or symptoms of hypovolemia within 24 hours after birth. If she looks hypovolemic and is acting hypovolemic, we're not going to sit there and argue about what her EBL was or what her QBL was. There's probably been an unrecognized blood loss. We know that 1/3 of women who have a blood loss more than a liter have no risk factors for an OB hemorrhage, just like that woman in the case. And we know that in Louisiana, 17% of our pregnancy-related deaths are explained by OB hemorrhage, and about half of our severe maternal morbidity, which is sort of getting at the question that you were asking. So here's an example risk assessment. Now, I don't know if you're aware, but most of your patients here at East Jeff are getting risk assessed for their hemorrhage risk when they arrive on the labor floor. This is an example of a risk assessment structure from California. So a woman who's low risk for hemorrhage may have no uterine incision, a singleton pregnancy, She will have fewer than 4 births. She has no history of a hemorrhage. There are medium risk factors and there are high risk factors. And so there are things that we can do on the labor floor that help prepare us. So the medium risk factors, that woman should definitely have a type-in screen. Now, I think most of our patients are probably getting a type-in screen anyway. But in terms of that high-risk patient, in addition to actually crossing them from blood, what is the conversation that we're having with the anesthesiologist? Does the anesthesiologist know that this patient is high risk for hemorrhage? Are we huddling before the procedure? Are we huddling before the birth to make sure we are prepared, those uterotonics are in the room or that hemorrhage card is outside the room, so that we're not having these unnecessary delays in care? Now, this is how you're doing here at East Jefferson. So this is an example of one of the measures in that measurement strategy that I showed you that looked kind of boring. East Jeff is reporting on your risk assessment percentage every single month. Thank you to the back section for doing this work. So you can see that basically 100% of your patients are getting a risk assessment for hemorrhage as soon as they get to the labor floor. So that's also true at Toro where I work. But what I think about this as a provider at Toro is I'm like, well, our nurses are doing these risk assessments. I don't really know if I'm doing the best job I could be doing with like knowing what the risk assessment is, or changing my clinical behavior, changing my communication with my residents or with my nurses around what that risk assessment is. So I think there's some opportunities for continued improvement there. Now, here we get a little more controversial, quantification of blood loss. So why quantify blood loss? Well, in that catastrophic case, which is a very extreme example, but it's real and it happened here in Louisiana, we know that denial leads to delay, and we have all been there. Well, she's losing, but it looks okay. I'm going to close. It's probably going to be fine. But having that QBL is another data point to know, well, where am I already in my blood loss? It looks like 700 cc's, but maybe if I actually pause to weigh everything, it would actually seem like a little bit more. If quantification of blood loss is not routine and standard, we don't know how to do it, and our nurses don't know how to do it when they need to do it. So when a doc says, I'm worried, can you tell me, how much blood loss you think I've had? By that point, it's too late. If the nurse hasn't already been prepared in terms of knowing how to weigh things, how to measure things, we have to do it every time if we're going to do it at all, because it's a useless piece of information. And we know that denial and delay lead to terrible outcomes. Are you sure that you don't want to fill your plates? Should we take a pause and have people fill their plates? Should I get through the hemorrhage part and then you'll fill your plates and then we'll finish up the hypertension part? Because the food's like on the flame and I'm just like feeling like you should eat while you're listening. Okay, I'll take a pause in a second, we'll fill our plates and then we'll finish up. So with QBL versus EBL, the goal of are we doing QBL here? No, okay. So quantitative blood loss is a system where we are weighing our pads, where we're using graduated drapes so we can see how much blood has been lost. And we're checking our suction and we're adding everything up. And I would say that this is really an expectation at this point that a level 3 high-risk facility is doing a quantification of blood loss. I'm just going to go out on a limb and say that this is probably one of the few facilities in the New Orleans area that is not doing QBL right now, which is fine, but we may just want to get ourselves there. So we have been on the tour, we've been on the road show, visiting all the hospitals in Louisiana and the collaborative, and these are some of the things that we hear from people. Why should I do quantitative blood loss if it's not a good number? I know that this patient didn't have this kind of bleeding and the QBL came out 1900. Well, the goal is not a perfect number. The goal is to have another data point that helps promote great communication between a doctor and a nurse about what might be happening in the room. If a doc is super frustrated about the QBL, we invite the doctor to document their QBL, and we invite the nurse to document the QBL, and we have 2 data points about what may have happened during a complicated birth or a complicated delivery. We do know from experience, not just ours here in the state, but throughout the country where multiple hospitals are rolling this out at the same time, that there will be inaccuracies. There will be contamination with amniotic fluid. There will be contamination with urine. There will be blood clots and fluid in our drapes that make it hard for us to know how much of that stuff in the drape is actually blood. But we also know that QBL increases our knowledge of where we are with blood loss and is more accurate than estimated blood loss. And QBL can only become second nature for the team if we're doing it every single time. What I have seen from personal experience, and when I was in Boston, I was a QBL naysayer. I thought I was really good with estimating my blood loss. I kind of thought it was a waste of time. I felt like everyone was always fluttering around the operating room and it was distracting. Is that it helped me realize not just when I was under-calling blood loss, but also when I was over-calling blood loss, and that me calling a blood loss was often a reflection of how stressed I was by a case and not necessarily by what I was looking at in front of me. So if a patient had been challenging, I would feel like it was probably a 1500 cc blood loss because I had 1500 cc's of frustration in my heart. But if, it had been an easy case, I was more likely to call it a 600 cc blood loss. And that the nurses measuring and weighing really kind of gave me a more concrete assessment of what was happening, and it also helped me make sure that I was touching bases with my nurses about what was happening and how to be prepared. When we think about response to a hemorrhage, we want to think about having a unit standard obstetric management plan with checklists, support for our staff. This isn't in the AIM bundle, but we really want to think about patient and family partnership and communication. And we want to think about transforming our clinical spaces so we have a culture of debriefs and huddles. So a debrief is an art. What went well about this case? What didn't go well about this case? What do we want to change next time? What do we want to tell the family? And really drawing the whole team into that. And then bigger picture, maybe the month later, are we having a multidisciplinary review of our severe maternal morbidity cases and evaluating for systems issues and monitoring our metrics? Now, your team is doing an amazing job with monitoring metrics, reviewing cases. I think that there's probably a lot we can still do around debriefing and changing that floor culture and using the QBL as a communication tool. So we're going to switch to hypertension, but you should fill your plates first, then we'll come back and we'll talk for like 15 more minutes. Is that okay? Otherwise,